Welcome, everyone. Before we officially start, I wanted to introduce this year's winner of the Dr. Mark D'Antonio Award to Dr. Ruby Luna Ongaro. Come on up. Want to take a second? I'm going to look here, but I'm also looking here, is what I'm told. So that's not awkward. So hopefully I'm standing. I want to brag a little bit about Dr. Ruby Luna Ongaro. To tell you a little bit about why she was chosen for this award, why she was voted for this award, and we're very proud of her. So again, she's a second-year child and adolescent psychiatry fellow, and she was born along the U.S.-Mexico border in Texas. She spent much of her childhood in Mexico before immigrating to California with her family, where she completed high school in the Bay Area. She earned her bachelor's degree in biology from Johns Hopkins University and obtained her Doctor of Medicine from the University of California, San Francisco in 2020. Dr. Luna completed her adult psychiatry residency at UCSF, where she earned an area of distinction in cultural psychiatry and was recognized as an American Psychiatric Association Child and Adolescent Psychiatry Fellow before pursuing her fellowship training at UCLA. It's very competitive. There's only like 10 in the country chosen for that award. Dr. Luna is committed to mental health equity and has been a strong advocate for policies to advance child mental health. Through her involvement in various APA committees and the California Academy of Child and Adolescent Psychiatry, CALICAP, she has advocated to support legislative initiatives to improve access to care for children and their families. In recognition of her advocacy work, she was awarded the CALICAP Wasserman Education Award in 2023. She currently serves as co-chair of the Diversity and Culture Committee of SCPS, where she leads initiatives to promote inclusivity and cultural responsive care in psychiatry. Some of her clinical interests include neurodevelopmental disorders, eating disorders within the Latino population, CL psychiatry, and interventional psychiatry, which she gave a ground rounds on last week, if you all want to catch it. Outside of work, Dr. Luna also enjoys cooking, dancing, and exploring the vibrant art and culinary scene in Los Angeles with her husband, recently married. So proud of her.
Again, this is the schizophrenic world we're living in. It's an honor and a delight to be able to introduce our second Mark D'Antonio lecturer, Dr. Tami Benton. Tami is chief and head of child psychiatry at Children's Hospital in Philadelphia, as well as professor at the Perelman School of Medicine at Penn. She is a noted researcher in juvenile suicide, especially as it affects minority youth. She has innumerable awards for her leadership and her research. And that's the bio you can read. But I actually just want to take a couple minutes to introduce her really in the way I was introduced to her, which actually was through Mark D'Antonio. Very early on, I was like a second week of my fellowship on Mark's service, who was a young attending at the time. And I was sitting in his office and he dropped a stack of papers in front of me. He said, "Here are your papers. I don't write articles. I don't do research. I'm interested in taking care of patients and teaching." And he was excellent at both. But he was also very passionate about issues pertaining to youth. And earlier in his career, Mark did a lot of work on the with ACAP in terms of youth and HIV and AIDS. And he was very involved in all of that for many years. And I guess through that, he worked with Dr. Benton. Well, fast forward to maybe 6 or 7 years ago now, I was about to become chair of ACAP's program committee. And the system that had been set up is you serve for deputy chair for 4 years, and then you move up to be chair. And I was appointed with deputy with Boris Beermacher, who was chair. Boris and I didn't know each other from Adam, and I didn't know Tami really from Adam or Eve. But that was kind of how it worked. I think when we initially started working together, it was a little uncomfortable because neither of us really knew anything about the other person. We do share some things in common. We have both spent considerable portions of our lives in New Jersey. Um, I think we are both very dedicated parents and really very dedicated to the field. I think at times, and I would say I think we built a great partnership. I now count her as one of my favorite humans. Um, she's friendly with my wife. We've had her to our home. But I think Tami will agree. She had more time. There were times we had discussions, conversations that I would describe, or she has described as maybe either uncomfortable or difficult. But they were always done, I think, and I think she would agree, from a place of respect and really a wish just to get it right. So Tami failed in her destiny to become my successor as program chair. Uh, she had a higher calling to be president of ACAP, which she actually discussed. We chatted about it when that call came. I think the Academy agreed that she was the right person for the time. And I believe she certainly was. She's now in the second year of her 2-year term and has continued to provide amazing leadership, amazing mentoring. And it's really delightful that she's with us today. Let me just say, actually, let me thank Polly and the Union Antonio family for this opportunity. It was weird post-COVID. 90% of our work is by Zoom world. We actually don't get together too much, but it's wonderful to have a chance to get together. Tammy and I also share the traits that we choke up when we talk about things that are important. But it's really nice to get together in Mark's memory. So we appreciate that. So with that, let me have Dr. Benton.
Jim is right. We do share that characteristic of tearing up. So I'm just preparing you ahead of time. He'll start it off, I'll finish it up. So I'm really thrilled to be here with all of you today. Polly, thank you so much for thinking of me and thank you for inviting me. I'm going to tear up early, so Mark was a friend and mentor. And I think that I've learned that the way I deal with grief and conflict and trauma is I just put it to the side until I have to talk about it. And so I want to share with you things I learned from Mark D'Antonio, things that all of us have learned from Mark, and the work that we continue to carry forward that Mark said it. It's really important. I also want to say that I really appreciate this, especially given all the things that have been happening in your community. And I think you are such an example of a resilient community. And so it's nice to be here with you all today. So what I want to talk about today is what has been the presidential theme for ACAP for the last year. The presidency, it's a long period of time. It's like 2 years president-elect, 2 years president, 2 years immediate past president. People tell me when you're immediate past president, you're sort of like dead because nobody wants to be anymore. And I would actually kind of be okay with that at this juncture. And so, but during the 2 years prior to this, it was around the time of the pandemic. So there was a lot of focus by my colleague Warren Ng on creating a sense of belonging for the community. And that was a lot of the focus. Bringing the village to the children was about creating a larger sense of community. Who are we as professionals? Who are we as human beings? And then how do we take all these skills that we have to make up a better place for our children and families? And that's what bringing the village to the children is all about. It's partnering with all the organizations and groups and individuals that are required to build a community for young people. And so the reason I want to talk about bringing the village really has to do with Mark and Mark's work around shaping policy and practice. And so I'll tell you the story of Mark, but I also think it's important to start off by saying that at the time that Mark D'Antonio and a small group of scrappy people decided they were going to push forward this advocacy agenda, the field was not on board. And there was a strong sense that psychiatrists stay in their lane. And their lane is you talk about children's mental health. You don't talk about the bigger picture. So I want to just highlight, it took quite a bit of courage to move this forward. So I just want to give you, because the slides aren't going to move, I just want to give you, I have no specific disclosures. This is really an advocacy focused talk, so I would like for people to kind of walk away with a few things that they can do. So I just want to give you some scope of the problem for people that aren't thinking about this every day. So there are close to 2 billion children in the world, and they make up about a third of the population of the world. And interestingly, in the United States, the population of young people is not increasing at a rapid rate. You know, people are having fewer children. Um, in the world, about 1 in 7 people who are 10 to 19 are experiencing some mental health condition, but the majority of those people who are struggling don't ever receive any care. And it's not all that different in the United States. In the US, there are 73 million children under 18 years of age. And as I mentioned, our population is not increasing rapidly in the US. Close to 8 million children have a treatable mental illness and less than half receive care. And like, I don't think these numbers are new to people, but I think when we look at these numbers, I don't think very much about the fact that a lot of these kids, I mean, they're not the worried well kids. If they study a little more because they're anxious, they'll do really well. These are kids who are actually struggling. And these are kids who don't get care for a long time. So if your onset of your illness is at 10 and you're 20 by the time you receive care, you have actually not received the intervention that you needed for the majority of your formative years where you're developing your education and preparing for your vocation. About a quarter of these kids are experiencing illness with significant impairment, right? Which means they are visibly struggling with people and not receiving care. And about 11% of 8 to 11-year-olds are experiencing severe impairment. So it's a significant problem that people are aware of, but there's been challenges with access to care. And then, of course, there's the tip of the iceberg, and suicide attempts are the tip of the iceberg. So many kids with mental health conditions never make a suicide attempt. But I select these slides because I think it's important for us to recognize that things are not exactly heading in the right direction around the things that we know are challenges. So when we look at the suicide attempt rate, and this is the data that the CDC collects every 2 years, they're just random kids in high school, so it's not a clinical sample. These are kids who are just going to school every day, and they ask them questions about health-related experiences. And what you see is that we're still, the red marks, I really like that because it's like really clear about what's not working well. And that if you see the red, you see that for Black youth and white youth, rates of suicide attempts are not heading in the right direction. We're doing better with certain groups, but the reality is that what you'd like to see is that all of these should be declining because kids are getting what they need. When we look at young people who have made suicide attempts in the last year, you know, what you'll notice is there's not equally distributed. So there's certain populations of youth who are at greater risk. Youth that tend to be minoritized or more vulnerable. So if you look at, you'll notice that AAP, Asian American Pacific Islander youth are doing worse. Youth who identify as gender and sexual minority youth are doing worse. And that in general, those groups are more vulnerable to all the forces that impact young people. So those populations are at greater risk. And then when you look at firearm related injuries, and I'm not going to spend a lot of time on this because I want to come back to this at the end, because I think it's important. When people talk about advocacy, you know, it sort of sounds like we think everybody's got time to go carry a poster somewhere in Washington, D.C. and protest. And people, sometimes they don't have time. Sometimes they don't want to do that. But there are things that we can do. And firearm violence is one of the things that we have an opportunity to do something about that doesn't take us a whole lot of time. But if you'll notice, the number of firearm assaults for kids 1 to 19, it is the most common cause of death for young people in the United States right now is firearm-related violence. We never thought we'd get here, but this is where we are. And it's primarily firearm violence related to assaults, not suicide attempts. Although we are seeing increasing rates of firearm-related injuries and deaths related to for young people. But basically, this is one of the major public health problems now. And then, as I mentioned, it's all not equally distributed. So there's some groups who are struggling more than others. So it's not just minoritized populations, it is girls. And most of our recent data around young women is really not positive. And so when we look at the data from the last Youth Risk Behavior Survey, the number of girls who are reporting that they felt sad or hopeless in the last year. This is data published in 2023 that was collected through 2021. But nearly 3 in 5 girls felt sad and hopeless. About 20% of girls reported experiencing sexual violence in the past year, and about 14% report having been forced to have sex. Native American, Alaskan Native girls actually have these experiences more. And then we've noticed over time, between 2001 and 2017, that there's been a 182% increase in suicide deaths for Black females, for Black girls. And then we saw a lot more suicide attempts for girls from 2011 to 2021. So we know that girls have become a population who's more, well, let me just say this, they were always more vulnerable, but I think right now it's pretty clear to us that girls are struggling more. So in case we hadn't noticed before, the world around us affects us. I think during the pandemic, we had more time to reflect. But one of the things that I think a lot of us reflected on at that time is, why was this happening in the first place and how did we get here? So I wish I could say children's mental health became a problem during the pandemic. It didn't. It was a major problem before that. And then when the pandemic happened, it really highlighted and escalated those things, and we became much more aware of it. And it was much more national attention because a lot of things were happening, but we really couldn't do a lot about it. The hospitals were closed, the clinics were closed. But we did have to spend some time reflecting on what are the root causes, the challenges that we're facing now. And the reality is that many of the factors that contribute to poor mental health outcome are social factors that drive health outcomes. And economic challenges, we're aware of that: poverty, poor employment, poor neighborhoods where there's a lot of violence, aggression, no green space, no place for kids to get out, poor schools, or overcrowded schools, or schools where there are a lot of violence, malnutrition, food insecurity, community stress, lack of engagement. And when I talk about engagement, it's not just the schools, right? I mean, I live in West Philadelphia. I don't know why there's 140 churches in West Philadelphia, but there are. And that is the community. So if kids can't be engaged in school, they can certainly be engaged in a church in West Philadelphia. And then we also know that as medical providers, we only drive about 20% of health outcomes. So that nothing that we do is going to make any difference if we're not aligned with all these other systems that support the needs of children and families. And so previously, I think, like we always knew this. I think part of the problem is that when a kid is sitting in your office with his family, what am I going to do about the poverty? You know, what am I going to do about the bad neighborhood? And so as a result, we know these things, but I don't think they're integrated into our treatment plans, right? The fact that we think about it, but we don't know that we can do anything about it, doesn't allow us to create a framework for creating a treatment plan where kids will actually get better. And so we're starting to think about that more. And more mental health professionals, more psychiatrists are actually starting to use what's called an exposomal framework. And the exposome actually incorporates all the biologic vulnerabilities we know about, all the other things that contribute to mental illnesses, including genetics and those things that you don't have a lot of control over. But all of these other factors modify those outcomes. And so now we're starting to think more broadly, how do we develop a framework for incorporating all those things into how we think about diagnosis and treatment? So what are the things that derail normal development? And we know what they are. All of these things, I don't think we need to spend a whole lecture on this. The reality is that we know these things contribute to poor health outcomes. And then when we look around us, you know, what you'll notice from the CDC data, and why I included this, really because more kids are exposed to risk. So these are kids who have been basically unhoused for 30 days. And what we're seeing is increasing rates of children who are living on the streets. And, you know, we know that despite the fact that we have learned over the last few years that all of these factors impact health, we've not done a whole lot to change the circumstances that expose young people to stress. Now, I did not want to spend the whole lecture telling you bad news. because I feel like it's important to have a framework for understanding what we're facing. But I also think that there are lots of factors that contribute to what we're seeing right now. So there are definitely the social determinants of health, which I believe very much are root causes for much of what we're seeing now. But there are also other factors. There's shortages of clinicians who provide care for young people. About 70% of the counties in the United States have no child psychiatrists. Okay, so if you need care, you're not likely to receive it. And then about 20% of all kids are living in those counties where they actually have no child psychiatrist. And so then we think, okay, well, we'll just use the rest of the workforce, right? Um, there 25,000 may sound like a lot of psychologists, but it really isn't. I mean, when you think about your average kid who's going to need treatment for a mental health condition, they may see their psychiatrist once a month, once they're stable. They're more likely to see a psychologist that they have to see several times in a month. And so the numbers are not large. Developmental behavioral pediatrics, there's only 900 of them, and about half of them are planning on retiring. So I'm not counting on that as a robust workforce. Okay, and then the social work workforce, a lot of them leave the clinical area and start to do more administrative work. And then for the people that we have, I don't think we use them very efficiently. The other major challenge to addressing this problem is financing. And so 1 in 5 individuals in the United States are funded by Medicaid. 40% of those are children. 60% of them are the elderly and other people with disabilities. So the reality is that not only does Medicaid underfund and undersupport young people, they're now talking about changing it, right? And so, we know that federal dollars match state level Medicaid funds, and they're talking about stopping the expansion. And so they want to decrease the amount of money that's actually being provided for Medicaid. And so, but the funding has been a persistent problem. And parity has been another problem. Okay, even when we should be paid for mental health services, we're not paid in the same way that the other specialties actually are. So around the time that this was all coming to a head during the pandemic, for the first time, the 3 largest organizations caring for children in the United States got together to call national attention to this problem, a problem that had been building for quite some time. And that declaration was powerful. I will admit, at the time I was participating in it, I thought it was a really good idea. I wasn't sure it was going to be impactful, but it was. And so we got together and we came up with a set of principles to guide behavioral health care. Prevention, early identification, and intervention at the time that problems are identified in the community. And the reason we had to call this out, because it has not been in the practice of child psychiatrists. Child psychiatry in general, has been marginalized to a practice of only treating illness. And despite the fact that we understand what well-being is and what's required for mental health, they don't pay you for that. And so it's not a routine part of our practice. School-based mental health has also become not a routine part of our practice. So in terms of cost and who does that work, it's typically not been child psychiatrists. Integrated behavioral health and pediatric primary care. We wanted to do that for a long time, but we couldn't be paid for it. So all of the principles were really focused on what is it that we needed to advocate for together on behalf of young people in our country. And these were the principles, the 9 principles that guided the declaration. And then a lot of things happened, and that's all I'll say about this slide. So around the time this all happened, there was a lot of congressional hearings. The nice thing about the congressional hearings is they were bipartisan hearings. And there was a lot of interest in how are we going to address the crisis of children's mental health. I thought the Surgeon General did a wonderful job of getting into this discussion, but basically supporting the fact that the nation needed to focus on this. And that's a key component, the most important issue related to the Surgeon General's messaging, because people are like, why do you really care? Did the Surgeon General say anything about it? The goal of the Surgeon General's advisory is to focus all Americans on important issues that are relevant to all Americans. And that's why this was such an important moment. But we had to ask ourselves some serious questions. So we believe in psychiatry, it's our job to treat that 5% at the top and then that 20% in the middle. And then everybody else, that 75%, the healthy people, or the people we think are healthy, that it's really not our work to do much about that. And the question is is this the management approach that we should be taking to anybody's healthcare? Are there preventive things that we can do for that 75%? And we believe that there actually are, and they're not that hard to do, right? Is it really, okay, let me not say that. If you only got 15 minutes, it's hard to squeeze a lot of stuff in there. But talking about nutrition, talking about exercise, those are things we know about, but those are things that can be part of our preventive care. We have effective strategies that work for prevention and treatment. And so we have prevention that we implement in other settings like schools, primary care practices. We have parenting interventions that we know that work, particularly for parents who are at risk and for parents who are not at risk. So when I was coming up back in the old days, when I was a pediatric resident, it was my job to tell parents about that their 2-year-old does not read your mind and they're not trying to upset you on purpose. That was just part of my routine healthcare maintenance visits. You don't get that now because there's no time. Your routine healthcare maintenance instructions are on your after visit summary. And so it's just all of those supports that we previously had that were paid for, we don't really have them now. We have psychotherapies that bring you to remission. Many of them are brief. And we have pharmacotherapies that work. Not as many as in adults, but we have them. These evidence-based interventions, and right now we're having a moment with all the things happening at NIH. A lot of the interventions that we developed had not really been tested in real-life community settings, but intervention science has allowed us to, implementation science has allowed us to do that. So not only do we have a lot of interventions that work, we have a lot of interventions that work in real life to treat most of the conditions that young people are facing. But we also have things we can do downstream. Basic parenting, supporting parents and helping their kids regulate their emotions. There are things that we can do. They don't even take mental health professionals, right? I find a lot of ministers do a lot of good stuff. Grandparents are really good at helping young people and families learn how to regulate emotions. And these are some of the tools that we need to utilize if we want to support the mental health of our nation. So we have a chance. Okay, we had a chance. There've been a few changes and new things that we have to face. But we have an opportunity to think about how we're going to have the kind of world we want for our children. And what we want is a nation of healthy individuals who can contribute to the best of their ability. And we want to create that kind of environment for them. So what does that look like? So how will we shape the future of children's mental health? And we have to think about our work differently. We need to develop new partnerships. We need to engage all community systems of care. So when I ask my patients if they have a church, because there's 140 of them around my office, they say no. I suggested maybe they want to explore one. And they say, oh, I didn't know you were so religious. And I say, I'm actually not. The reason I'm suggesting this is that faith-based communities have some nice people in them. And if you're here by yourself with your children, you have no family around, you can't find a sitter, it's important to join some kind of community. And that's what young people need. But we need to have partnerships with those people because we can't have them telling people that your soul is weak if you take SSRIs. We have to form a partnership around how can we work together to support children and families. We need to engage all the communities, whether we agree with them or not. And, because they're involved in the lives of young people. And then we need to find ways to reduce stigma. And the only way to do that is by having these conversations in the places that folks are every day. We need to elevate youth voices and family voices. We need to listen to them when they talk to us about their mental health and not I don't want to judge the whole field, but my experience, when I called myself listening to families, I heard what they had to say. I acknowledged that I heard it, and then I did what I wanted to do. That's not the kind of partnerships we're talking about. It is about allowing them to inform their own treatment. And then we need to expand access to timely and appropriate care. And I don't buy the argument, there's just not enough people to do that. I don't think that's completely accurate. I think that's part of the problem. I think the way we provide care is the other problem. So what do we need? Ideally, a continuum. So we want people to start receiving whatever they need in their communities, schools, primary care centers. If they need outpatient specialty care, they should have that. If they need higher levels of care, they should have those things and have access to those things. Telehealth is an enabler. So it allows us to expand capacity and access and to do some things differently. The mobile crisis team, I think 988 has been incredible. I think it's underutilized. It didn't roll out well, but it's a nice intervention. Teenagers like it and they'll use it. And for those that you don't know the 988, it's the mental health 911. And it's a good service. And then there's health prevention and promotion. And this is where I think we need to focus a lot of our time and recognize that this actually is in our lane. This is what medical professionals and child psychiatrists should be doing. So we have tiered levels of care in schools. Basically, there are things we give everybody. Meditation, wellness. Somebody sent me a singing bowl, and I did not know what it was. And so I asked my son, like, why would somebody send me this bowl with this thing in it? And he was like, Mom, it's a singing bowl. And I was like, that's not very helpful. And so he explained to me what it was. And then I said, like, why do you know what it is? And he said, because we did this in kindergarten. And those are things you can do that don't cost you anything. Identifying the kids early who are struggling and addressing it, identifying kids who are at risk, and then treating those kids in a school setting as much as possible without having to take them out of their school setting. We've done some pretty innovative things. So in all that stuff that we didn't talk about, all that action, some good things came out of that. Increased funding for school-based mental health care came out of all of that work. Expansion of what's called the access program. So access programs where there's a child psychiatrist who's been supported by the state and by the federal government to respond to questions pediatricians have in primary care within 30 minutes of the phone call are now available in 50 states. And so it allows the pediatricians to be able to provide more care in the primary care setting and not having to send families somewhere else. ECHO has really expanded. Sometimes ECHO is great. Sometimes it could be greater. But ECHO is a project where you have to use a digital platform to educate typically a group of primary care providers about a topic of relevance or importance, such as autism. And it allows them to build their skills and to develop knowledge about populations of kids that they're seeing. And now the ECHO programs have become very, very popular. I think they're now using them for perinatal mental health. So they're working with postpartum moms. And so it's a strategy that's been funded more by the federal government that's been helpful since the pandemic. And so at the end of the day, we really have to change our mindset about how we think about children's mental health. And it's better to engage in prevention than what the downstream effects are that we've not been able to effectively manage. So what are some of our opportunities? And since I'm in California, I suspect that you guys are probably more digitally engaged than we are in the rest of the country. So I think there are lots of opportunities for us to expand access to care using technology, creating more efficient first response systems. And I think 988 is a good example of that. And then addressing the shortage of skilled mental health workers. And this, I think, needs to be an increased area of focus. I'm going to skip this because I said this already. And then one of the things that came out of the pandemic is the ability to use digital platforms to expand capacity for non-specialist providers. And so one of the projects, now with global mental health, people are communicating more using technology. We're actually allowed to share skills around brief psychological interventions. And that we're also able to train non-specialist providers to be able to provide some basic components of mental health care. And I'll give you one example, from my colleague, Vikram Patel, who we partnered with around developing depression interventions in communities using daycare workers to execute certain modules of cognitive behavioral therapy. So Vikram has an intervention called Empower. And what Empower does, implemented in India with people in small communities, where he trained them they're trained digitally to exercise particular interventions. The behavioral activation module of cognitive behavioral therapy is one of them. And so some of these are grandmas or they're the neighbors. They monitor fidelity because digitally you can see what people are doing. But what it allows them to do is expand access to some services that don't need to be provided by a professional. We're actually piloting this in West Philadelphia right now with after-school workers. But there's an opportunity for us to expand what people need without waiting for 8 years to train another professional. There's another project at Penn called Impact that I just learned about last year. It's really focused on medical patients. They actually find a group of community workers and they train them in basically how to interact with patients who are in the community. They hire people from the community, they train them, and then the goal of the community workers is really to do what the individual wants them to do. So for example, if they can't get their medications because their pharmacy is too far away, the community worker helps them. If they want to learn to play chess, the community worker helps them to do that. Impact has been impactful because they've actually decreased costs and decreased hospitalizations. So these are just some of the interventions, and there are more, but these are some of the interventions that actually have been pretty successful. And so, so one of the things that I think that we can do around expanding access really has to do with expanding our reach. And these are not, I don't think these are complicated things, but it's one of the ways that we can expand access to care without necessarily having to expand the number of providers. And at the end, what I hope that we would see is a system of care that's actually tailored to the needs of young people. That at the center of our care model should be the children and families that we want to take care of. And that all of these interventions and relationships are partnerships, and that the service continuum that we provide is actually what young people need. In order for us to do this, we're going to have to do some things. And, you know, I think we've all learned that our world, as we have known it, as medical professionals and scientists, can change with an order and a signature in a day. And so clearly, all the things that we've been doing are not the only tools that we're going to need if we want the health of the nation. And so what will we need to do? I think we'll need to make some commitments to stepping into this place that's not that comfortable and stepping into a place that's not in our lane. I don't like talking about Medicaid, but I need to know about Medicaid. And I need to be able to talk to the people who impact Medicaid about Medicaid. I need to be able to talk to the other people that influence my work. So if I'm in the emergency department with the kid who needs to go to foster care, I need to be able to pick up the phone and call somebody in DHS who can help me. I need to look at how we provide care and make changes. We need to complain when there's no green space in the neighborhood for kids who are living in terrible conditions. All of these things are in our lanes. They're not necessarily things that require us to go outside and protest. Look, if you want to go protest, I'll go with you. I'm on board with that. But a lot of times folks are just saying, like, what can I do? And we know most of these policies happen at the state level. So, you know, I pay taxes. I feel like someone should respond to me. And so picking up the phone, having a conversation with people, educating people in your community, those are commitments that we need to make. And we don't need to do all of this, but we all need to do some of it, or none of this is going to change. So what have we accomplished? Okay, because we've done a lot of work in this area, a lot of things. Okay, and I talked about the big one, so I won't spend time talking about it now because I want to make sure I have some time to talk about Mark. We've had some major legislative wins. Okay, so that all changed in the last few weeks. Okay, requiring us to shift our focus, but the principles are the same. We still need to be engaged. And then this is a resilient community, and we are a resilient community. And whatever happens, you know, over the coming years, we'll be fine because we're going to do something about it. And we're going to develop a strategy for how we're going to respond to support the things that we believe in. So I just want to briefly talk about firearms because I think it's a specific issue that has many potential options for advocacy. So we know that firearm deaths are increasing, as I mentioned before. And now it's become the most common cause of death. If you look at the numbers, okay, of the number of children who die by firearm deaths, they're little children. Okay, they're children under 11. And then for adolescents, you know, a lot of adolescents die by firearms, but it's mostly based on acts, mostly assaults. So it's not mostly suicide. We also see that this isn't evenly distributed either, that Black kids are much more likely to die by firearm-related violence than other groups of kids. And so what does this have to do with Mark D'Antonio? So Mark, I got to know Mark when I was on the HIV committee. Sorry, I warned you. Um, and Mark was, I don't even know how to describe Mark. He was non-traditional. He followed his inner beliefs and he had courage. And he encouraged all of us to do that. And he instilled this idea that it is our responsibility to speak for people who cannot speak for themselves. And he lived that. He also taught me about how to stand up for myself when interacting with more powerful people. And my first experience was with him. And I went to him to, I didn't really complain, but I was hurt that he hadn't considered me for something. And I was struggling a little bit to tell him that. And finally, he like helped me say it. And he was like, "That's what you wanted?" I was like, "Yes." He's like, "I've been trying to get rid of this thing. Why didn't you tell me before?" And I was like, I didn't have an answer. But I really learned a lot from him. And so he was instrumental in establishing the Political Action Committee. This was a big deal because the time that Mark started this small group of scrappy people wanting to do advocacy, they had a whole lot of resistance from the leadership of the American Academy of Child and Adolescent Psychiatry. Mark didn't care. He knew it needed to happen. He knew that our mission, which now includes advocacy, was really to be the voice for young people in our country, that if we couldn't speak up for them, who could? And so essentially, Mark drove this mission. This was the first PAC, and Mark was one of the founding members. And I don't know if you remember this, Pauline, but he was one of the founding members. And this was his little scrappy group. Warren Ng, the immediate past president, we both worked with Mark on the HIV committee, so we had a prior relationship. Jim, you see how old this picture is? But basically, Mark was one of the founding members. And despite the pushback, he kept moving forward. The ACAP PAC eventually developed a board, and he was one of the first board members. And he continued to lead the development of the PAC. He was a key player in establishing this group. And if he hadn't, think of where we'd be right now. But he was a key leader in driving this group. But like I said, it was a small group. It took a little while to catch on, but eventually he was able to engage other members. And then he was one of our best fundraisers. So that in addition to the ideal, he made it real. And he spent his time raising money to support the PAC, encouraging the members. Like I got a phone call the other night in my car, I pulled over, and they were like, "Can you give some money to the PAC?" I was like, "What? How do you even have my cell phone?" But basically, Mark was the one who really worked with this group to strategize how we were going to make this a reality, because he had a vision for what we should be doing. And he felt very strongly, we need to be talking to the right people, to all the people about what we need for children's mental health. And so the PAC grew. And as you can see, eventually it was co-opted and people acted like they'd always wanted it, which is what always happens. But the PAC really developed. And in addition to his presence with the PAC, Mark was present in so many other places. So he was the person who oversaw all of our media for our annual meeting. The HIV committee was a passion project. We were a small but mighty committee. And I think, though we may not have understood it at the time, that the principles that Mark held dear are the ones that they became dear to us. And so the PAC continued to develop and grow over time, and it's become a legacy of Mark's at this juncture, because we can't talk about the PAC without talking about it. And I just want to share this message from the Academy staff, who sent a special message for Mark. So the Academy staff have been with us for a really long time. And they worked with Mark for many years. They don't have a high rate of turnover. But they talked about Mark's contributions were, they called him Dr. D'Antonio. He was never Mark. I actually called him Dr. D'Antonio too. His contributions were instrumental in the early successes of ACAP PAC. His legacy continues to inspire advocacy efforts and the mission of ACAP in supporting child and adolescent psychiatry. His leadership, generosity, and unwavering dedication to the field have left an indelible mark on ACAP, ensuring that his impact will be felt for years. And I want to show you where it translates most immediately. So Warren Ng was our past president for ACAP, and I'm the current president. And this is where we spend a good part of our time. And we spend a good part of our time involved in advocacy activities on behalf of the American Academy of Child and Adolescent Psychiatry. We learn the lessons well. And we learn that you have to take risks and you have to put yourself out there and you have to be consistently committed to your principles and priorities. So no matter what happens, we're not going to be an organization that steps away from our priorities. And that means the things we believe in, we still believe in, and we will continue to believe in them, and we will support our members in advocating for them. And this is where we are now. So the advocacy initiative in ACAP has become foundational for how the organization operates. I wish Mark could be here to see all this, but he has really nurtured the identities of a generation of professionals. And I think on that note, I'll stop talking. Question, comments? I'll be okay. This is normal.
I was curious about the mandate to bring the interventions to the schools.
Yes.
Is that coming from the federal Department of Education or states?
So that
Because
came,
I would think there would be a lot of variation in the.
yeah, so it wasn't so much from the Department of Education. It was actually a congressional award. So the funds were provided during the pandemic. And so the funds were provided for school mental health. Unfortunately, those funds started to run out for people, so they had to start looking for state level funding. But I think those are where the opportunities are. Some schools had a lot of resources focused on mental health. So if you were, unfortunately, there's always that problem that if you're in a wealthy district, you have more resources. And then a lot of the communities were under-resourced, so they actually benefited more from federal dollars. But when the federal dollars went away, a lot of the services went away as well. Schools are a great place to provide funding and mental health treatment because the kids are there, their families come, and it's a place where you can do a lot of prevention. But I think there's some that did not come through the Department of Education. That being said, there were still plenty of opportunities to not provide any more funding. So I think that is a great advocacy opportunities for communities and states, because that's also where a lot of those decisions are made. Yes.
Given that the current situation is
The current situation.
the current situation, I can't think of another way to say it.
I think that's an excellent way to say it.
But given that what we're dealing with is a world in which mention of things that we know to be critical in thinking about child mental health and other issues, gender, socioeconomics, sexuality, whatever, race, are being explicitly eliminated from the conversation. Well, how do you see us going forward in delivering care, especially in the schools, where the intersection may really be equal?
Well, and so that's one of the things that we've really been struggling with, and working in partnerships with other organizations. Just today, we're going to issue another statement, a joint statement with the American Psychiatric Association, really around continuing to support our position around gender affirming care. We can't step away from those issues because it's right. But at the same time, we also realize that we have to be some ways pragmatic about our language use for legal reasons. Fortunately, for a lot of the private organizations, you're not necessarily facing some of the same challenges. You have to decide that you're going to be targeted, and you sort of need to be okay with that. And so ACAP has decided we're not going to step away from our principles. That being said, there are legal things. And so a lot of people have changed their language. And so, for example, somebody sent me like this whole article last night on things you can say rather than saying this. Okay, and so I know exactly that's going to be a challenge for me anyway. But basically, I do think we're going to have to be a little more strategic in our thinking. Um, Unfortunately, so many things are happening that are really bad. You can't ignore them. Because I guess some people think like, look, 4 years will be over. I don't think so. I mean, there's too much bad stuff happening around you, and it's not going to be over in 4 years. But I do think that it's going to be really important to stay focused on your priorities because it's easy to get distracted. I mean, it's like you're in a war and people are throwing landmines all around you, while at the same time you have to focus on getting to where you want to go. And so we had to decide that our strategy is going to require us to think about what are the core things we have to do, and then we're joining with other organizations in supporting those other things that are important, like gender affirming care, diversity, equity, inclusion. I mean, I know that's not the phrase you should use anymore, but it's how you use that phrase, right? So it's preference. Okay, it's not about diversity. People are continuing with diversity because it's a good business decision. It's not because I mean, maybe their hearts are in it, who knows? But from a financial perspective, it's just good business. And so folks are going to move forward with that while at the same time trying to avoid the legal challenges. And then I think we've all concluded we're just got to rely on the courts. Now, that can be scary, okay, given the way things have been, but there really is not another consistent strategy. And that you can't file suits as quickly as things come down the pike, but around the big things that are important, I think that is a strategy that we're going to have to support. And then the other thing is, I pay a lot of taxes in Cherry Hill, New Jersey, and I expect my local representatives to pick up the phone when I call, and have some interest in, what's important to me. And I think we all need to exercise that because those people, believe it or not, somebody calls you back. But I think we really need to be at the state level and at the regional level talking to folks about what's on our minds and what's important, because people respond to that. So I'm sorry, that's not a good answer, but it's the strategy we use. It's not a good situation. That being said, I am trying really hard, and I think we all need to keep this in mind. It's a tough time. I'm Black, okay? For me, life is interesting. And I will say that, as this is Black History Month, there was a civil rights movement. Why did that happen? It happened because of stuff like this. And so like we have been here before. We've done this already, and we can do this again, but we have to stick together. We have to support each other. I don't agree with everybody, okay? And that's fine, okay? As long as we can work together around the things that are our priorities. And if we learn nothing else from the things we've gone through in this country, it is that I still believe that the American spirit, even though people are confused right now, at the core, really want for us to be able to work together, have a happy life, get along with people. Like, I think those are still core to people's beliefs, and I think we have to hold on to that. Of course, you're in charge. We can do whatever you want to do.
What a beautiful and timely talk. And I just wonder if you could give us a few more pearls around how we can build that muscle as mental health practitioners to do advocacy, to do partnership with community organizations, local agencies, state and federal government. What are some of the really practical things that we can learn to begin to do in that vein?
So one of the things that we've been doing that's been a relatively easy win is inviting community members into our spaces. So, our outpatient practices after hours, we invite people in for things like mental health first aid training, we invite them in sometimes to do trainings for us. And so we've actually engaged in a lot more community engagement because that has actually strengthened other relationships. So, for example, since I live in Cherry Hill, New Jersey, I work in Philadelphia, I don't vote in Pennsylvania. I vote in New Jersey. Unfortunately, I have a governor that's like pretty easy to work with. But at the same time, we've had more impact by inviting community members in our spaces. So we offer a lot of trainings. We have partnered more with the schools. And so a lot of times the schools don't have a lot of resources, but typically if you say like, look, if you want us to come talk to your teachers about how to deal with, in my neighborhood, a third of the kids have disappeared from the schools. Teachers are calling ICE to report families. Okay, and then, the teachers are like, is there anything you can do to help support us and helping the other kids respond to those kind of things? And we offer those services at no cost to them. And so the same with churches. It's not like I used to go to church all the time. Anyway, you don't need to hear all that. The reality is that I did a faith-based thing with the APA, probably about a month ago. It was a Saturday, like at 2:00. I was shocked that this church was packed with people who wanted to learn more about mental health, and how to help their family members. So I think those are things we can do that aren't necessarily all that time consuming. Making the resources you have within your institution available more broadly. Yeah, I think it's another thing, because I always think of the hardest things to do that take the most time. The younger generation of people in my department, they don't do that. They come up with the quick wins, like we have like 80 pieces of material here that we could disseminate. Why don't we just send it to people? I was like, oh yeah, that's a really good idea. So, but I think that those things actually are things that really matter to folks. And then the other thing, I just have to say this, I'd be curious about your perspective. I learned something really important this year. So, at our annual meeting in Seattle, we actually had an individual with lived experience talk about growing up in foster care. And to me, it just seemed like the natural thing to do. Interestingly, a lot of our members said to me, I really didn't know what to expect when you decided to have a person with lived experience speaking, and it worked out okay. And I thought, well, that's really interesting because we say we want to do that, but what are we afraid of? And I think we're afraid that they're going to talk about all the bad stuff that somebody did somewhere and we'd all feel responsible for it. But I think the more we can get comfortable listening to people tell us about their experiences with us, even if it didn't go well, partnering with those folks, I think are some of the most powerful voices for change because they do vote and they do care about their communities and they talk to other people. So I think those partnerships, I think, could be really valuable.
Thank you.
Thank you.
Wonderful. Thank you, Tami, for coming.
Thank you, Ms. Whitehead.